All right, so we left off at poliomyelitis, right? It's just a viral disease, one of our neuromuscular disorders that are going to affect the lung. It's about 8 cases per year, and most of the new cases are rare, and they are related to vaccination. And most of the cases are going to occur in unvaccinated immigrants. 95% have of those infections are asymptomatic. But you know that polio can cause paralysis in those that are symptomatic. So fever, headache, vomiting, diarrhea, constipation, sore throat, right? Weakness, paralysis, respiratory failure, and then chronic respiratory insufficiency, right? Which is the reason why it is found in this chapter, right? Function generally recovers, right? So you're going to see amyotrophic lateral sclerosis, ALS, which has made it into the news more lately due to that ice bucket challenge that went around a few years ago. It is a degenerative disease of the nervous system and involves upper and lower motor neurons. So the multiple sclerosis involves upper motor neurons, and this one could be upper or lower motor neurons, which you know are in your, the upper motor neurons are from your primary motor cortex down to your spinal cord, and then the lower motor neurons are from your spinal cord out to your muscle. So you have irreversible and progressive deterioration of these nerves. Basically, sclerotic, just like multiple sclerosis. So you're going to see damage in the myelin as well. Right? So progressive muscle weakness and wasting, right? So muscles innervated from the spinal and even cranial nerves are affected. And then, of course, that leads to profound weakness of the respiratory muscles and death. So that respiratory muscle mainly is your diaphragm, right? And your phrenic nerve is the nerve that innervates your diaphragm. Remember, which is from cranial nerves 3, 4, and, cervical nerves 3, 4, and 5. Muscular dystrophies, there's a few different varieties, but the most common one is Duchenne's muscular dystrophy. It is hereditary, it's X-linked, it is due to a frameshift mutation, and it occurs in about 1 in 3,500 births, again, mostly males, because it is X-linked, so the mothers pass it down to her male children. It is very rare for it to be seen in a female, extremely rare. Progressive muscular weakness, right, initially in lower extremities, and you're going to see wasting, and basically they may be able to learn how to walk, and so on, but they are going to lose the ability to walk very early in childhood, and then eventually in the later years become where the respiratory muscles become involved about 20s or 30s, and that leads to hypoxia, hypercapnia, and frequent respiratory infections. Guillain-Barré, also called acute polyneuritis, right, is immunologic. Usually you'll see demyelination of peripheral nerves, and it is very common after a viral or bacterial illness in about 66% of cases. Guillain-Barré has also been shown as a side effect to some vaccinations. And infections involving Campylobacter jejuni often precede the diagnosis. So some of the manifestations of Guillain-Barré is what we call ascending paralysis. So paralysis beginning in the lower extremity and ascending proximally to the upper extremities and trunk. Some severe cases you'll see respiratory muscle weakness accompanying that limb and trunk symptoms. Most people have a full recovery as soon as their bodies basically can eliminate this, but many of this infection and these antibodies to this infection, But many people have some residual motor deficits, so about 15 to 20% do keep some of those deficits. Myasthenia gravis, another autoimmune disorder, and it's basically a weakness and fatigue of voluntary muscles. But myasthenia gravis involves the acetylcholine receptor at the neuromuscular junction. So you have mainly those innervated by cranial nerves. And so peripheral and respiratory muscles can be affected, right? So weakness that is worse with exercise and better with rest, right? So about 2 to 5 cases a year per million people in the United States, males more than females. And like I mentioned, it's an abnormality of the neuromuscular junction, right? Transmission from nerve to muscle is impaired because basically there is antibody attack on the acetylcholine receptors at the neuromuscular junction, right? So symptoms are often managed by therapy, physical therapy, again, rest, right? Respiratory failure can be due by increasing severity of the illness or over medication. That is also possible. Individual episodes of respiratory failure are potentially reversible. Kyphoscoliosis is one of our chest wall deformities that is also going to affect the ability for people to breathe. Its etiology is neuromuscular, as it includes several diagnoses that are going to limit the ability for the chest wall to expand, right? Many times it is idiopathic and is adolescence. Greater than 11 years is most common, and in females most common over males. So females 7 to 1. It is also can be congenital, which means that they're born with it, something called pot disease. Right. Pathogenesis, right, is a bone deformity of the chest wall resulting from kyphosis, which remember is kind of a hunched back that is at the high T and maybe lower cervical, so cervical thoracic, and scoliosis. So scoliosis, remember, is that S-shaped deformity of the spinal column, right? So if you have both of them, I just want you to try to appreciate that with that type of deformity, it is very hard to expand the lungs, because remember, the ribs are coming off of the thoracic spinal column, right? And those thoracic vertebra. So the more the deformity, right, the greater the compromise of respiratory status. The lung volumes can become even so compressed that it could lead to atelectasis, ventilation perfusion mismatch, and even hypoxemia. Dyspnea on exertion, rapid shallow breathing, and this chest wall deformity, again, ribs protruding backwards, right? Flaring on the convex side and crowded on the concave side, right? So think of an S shape, right? So they're flaring on the one side of the S, and they're kind of all crunched together on the inside of the S. And hypoxemia, and eventually carbon dioxide retention later in the disorder. So you could see there the kyphosis, right? You could see there in the upper thoracic, whereas this is scoliosis. And you could see the flaring right here and concave on this side. All right, so some pulmonary function tests. Right, hypercapnia and hypoxia is going to be seen, decreased lung volumes and capacities, increased pulmonary arterial pressures. X-rays, accentuated bony curves, right? Screening for scoliosis and kyphosis in school-age children is an excellent method to be able to catch this early and basically do whatever might be necessary to alleviate the situation. So treatment is curvatures less than 20 degrees. It's monitored, right? And then a type of braces for moderate scoliosis, and then postural exercises for mild kyphoscoliosis. So it really depends on the severity and the age of the patient. If your patient is older, you might not place braces, for example. So treatment if curvatures are greater than 40 degrees, right? See electrical stimulation of the paraspinal muscles. You might see spinal fusion or spinal instrumentation or rod placement, right, for surgical stabilization of that curvature and to eliminate or minimize that curvature, right? So curvatures of greater than 60 degrees have very poor pulmonary function. So that is the cause for great concern. Ankylosing spondylitis is also another type of curvature that is also autoimmune. And most people with ankylosing spondylitis are positive for the HLA-B27 antigen, like the majority of them. And it is much more common in males and females. The cause is really unknown. But the presence of this tissue antigen makes it more likely for the person to develop ankylosing spondylitis. And what you'll see is you'll see an acute arthritis of peripheral joints and then kind of a fusion, right, of the spine. So chronic inflammation at the site of your ligament insertion into the spine or sacroiliac joints. And then respiratory system is going to be affected by this limited chest expansion. And then you might see even pulmonary fibrosis in the upper lobes. So later develops also some bronchiectasis and cavitation. Is progressive inflammatory disease, becomes immobile, right, and fixation of ribs, right? So it affects all of the joints, sacroiliac, costovertebral, and articular processes, and basically leads to joint calcification, ligament ossification, and immobility. Right, so low to mid back pain and stiffness with prolonged rest, right? So and the pain and stiffness decrease with exercise. So again, this causes the restrictive type of lung dysfunction, where obviously, right, the fusion of the spine is going to restrict the rib cage from being able to. If you think about when you breathe, you actually raise your chest up. So a person who's now in a hunched back kyphosis type of position with a fused spinal column is not going to be able to use that bending your spine backwards to inhale deeper, right? So eventually, right, breathing by excursion of the diaphragm with rib cage immobilization. So that's basically all you have. Pulmonary function tests are going to find a decreased vital capacity, decreased total lung capacity, and decreased chest wall compliance. Chest x-rays are going to see destruction of cartilage, erosion of bone, and then calcification or bridging of joints. And then, of course, elevated sedimentation rate due to extra proteins in and that HLA-B27 antigen. And again, so that proteins in the blood, including antibodies and antigen antibody complexes, increase the sedimentation rate. And so treatment is breathing and mobility exercises with NSAIDs, also for pain. Flail chest, right, can result from multiple rib fractures due to trauma, right, to the chest wall, right? So rib fractures at two distant sites result like in a free-floating chest wall, and then paradoxically moves inward on inspiration and outward on expiration. So sternal fractures actually can cause that flail segment. So very common when the chest hits the steering wheel in people who have gotten in a car accident without wearing their seatbelts. right? So fracture leads to negative intrapleural pressure generation, because remember, the intrapleural pressure has to stay negative in relation to the pleural pressure, so that the lungs, because the intrapleural pressure is lower, it's going to keep the lungs inflated. So if you decrease or lose that intrapleural pressure, your lungs are going to collapse more easily, right? So causing decreased lung expansion on inspiration. You also can have parenchymal lung injury, like a contusion in the lung, and leading to some type of scarring, which is going to decrease lung compliance. Remember, compliance means elasticity, right? Respiratory failure, and then interstitial and alveolar hemorrhages as well. So again, clinical manifestations: trauma, paradoxical motion of the chest wall, shortness of breath, cyanosis, pain on inspiration, hypotension, hypoxemia, low arterial partial pressure of oxygen. You might also see some pneumothorax, hemothorax, or subcutaneous emphysema are also common with the flail chest deformity. And so the diagnosis is made with looking at those arterial blood gases, and can be managed with mechanical ventilation, right? So helping the entire chest move as a unit rather than separately or at the detachment point. And then obviously pain management with even epidural anesthesia if necessary. Then you also have excessive body fat and some disorders of obesity that can cause some restrictions in the ability to breathe, such as being excessive body fat, particularly much beyond the BMI of 30. So based on body weight and height, because remember, BMI is on basically, as you see, kilograms per meter squared. So it's based on your weight in kilograms divided by your height in meters squared, and that number is going to be, should be somewhere between about 18.5 and 24.9 for a normal BMI. The overweight BMI is between 25 and 29.9, right? So remember that BMI also does not take into account muscle development. So if there is a lot of muscle development particularly in males, which are bulkier, remember, women really don't bulk because we do not have the testosterone necessary to do that. The BMI has to kind of be take that into consideration. So if it is a male with a significant amount of muscle, then a BMI closer to 30 might not be as detrimental as it is for somebody who does not have a lot of muscle. Excessive caloric intake and or reduced caloric expenditure are some of the reasons that are going to account for obesity, right? More women than men. You will see more blacks than whites, people with lower income greater than people with higher income, right? So BMI being above 30 has a mortality that is 50 to 100% those of people with a BMI within a normal range. So obesity is definitely going to increase your likelihood of many disorders, including even cancer, right? So what is the pathogenesis for something like this is excessive caloric intake, and that is also going to be seen with a very little expenditure of calories, right? So several hormones act on brain receptors to regulate appetite and metabolism. So there could be a damage, for example, to the leptin receptors, right? The leptin receptors are going to be affected in a disease called Prader-Willi syndrome. You may have heard of that. So that's a genetic disorder that can lead to obesity because it has a defective leptin. And because they have a defective leptin receptor in the brain, they do not comprehend the concept of satiety. So satiety is a feeling of satisfaction that you have eaten what is necessary to sustain life. And so people who don't feel that just eat and eat and eat and eat. I mean, and Prader-Willi can be quite serious. I mean, these people eat to the point where they even can cause their stomachs to rupture because they have no they have no mental, right? They have no sign in their brain that they're full, right? So, also increasing metabolic rate. So leptin is, one of our, hormones that's going to regulate appetite, and the other one is ghrelin. So ghrelin is stimulatory, so it stimulates appetite. Right, so obesity is going to be associated with hypoventilation and airway obstruction. So Pickwickian syndrome is another one that causes an increased abdominal size, right? That forces thoracic contents up into the chest cavity, and that decreases lung expansion and diaphragmatic shortening. Right? Sleep apnea syndrome. So the soft tissues in the neck and these tissues then can hang backwards in such a way that it can block the upper airway. And so sleep apnea is much more common in people who are obese than in people who are not obese. Some clinical manifestations: decreased alveolar ventilation, severe hypoxemia, somnolence, just daytime sleepiness, right? Shortness of breath, polycythemia. So if you have hypoxemia, remember you are going to get some erythropoietin going, and you're going to make more red blood cells. You might see cor pulmonale. You might see impotence due to like lack or maybe even the polycythemia. And then headache and enuresis, which is urinating at night. So diagnosis obviously is self-evident on exam, but you also are going to do maybe arterial blood gases, and you're going to find hypoxemia, hypercapnia. Some pulmonary function tests will show a decreased chest wall compliance, a decreased vital capacity, total lung capacity, and expiratory reserve volume. So you might also look at some other comorbid factors in laboratory tests, such as diabetes, blood sugar, cortisol levels, and so on. So oxygen treatment and promoting a healthier diet that is going to create a energy deficit of about 500 to 1,000 kilocalories per day. So in other words, if you need, according to your current weight and your height, you need 3,000 calories to function, and we're talking this is somebody who's quite heavy, then you would put them on a 2,000 calorie a day diet, and then that is going to significantly improve the energy utilization of the body. So you mobilize fat stores, and you also will see a decrease in body weight. And then of course exercise, and it can be significantly stimulated by things like gastric bypass or gastric sleeve surgery, or maybe even lap band or the new gastric balloon. Okay, so stapling is sort of an older thing, so that is usually not offered anymore because gastric sleeve has sort of taken over for that. Right, so infections of the lung, right? You have pneumonia, right? Inflammatory reaction in the alveoli and interstitium caused by an infectious agent, right? So aspiration of oropharyngeal secretions composed of normal bacterial flora or gastric contents are one of the main causes. Inhalation of contaminants, contamination also from systemic circulation. Right, so pneumonia can be caused by many different things, right? Many different infectious agents. So the most common one is streptococcal pneumoniae, right? Which is what we get when we get the pneumococcal vaccine is for streptococcal or Streptococcus pneumoniae. That's the pneumococcal vaccine. But there are many other organisms that can cause pneumonia, right? Klebsiella pneumonia, you might see Pseudomonas, even pneumonia, and so on. Those are all very common organisms, right? So some of those are community acquired, some of them are hospital acquired, and you can have bacterial, viral, and even fungal, or some other atypical type of pneumonia. So who is at high risk for pneumonia? The elderly, those with a diminished gag reflex so that they are not able to cough, those who are seriously ill, hospitalized patients, even patients who are on ventilators, right? Hypoxic patients and immunocompromised patients, right? So anaerobic bacteria can present in lung abscesses, right? Necrotizing pneumonia, or even epidemia, remember, which is pus formation, and usually caused by some sort of normal oral bacteria aspirated into the lung. Mycoplasmal pneumonia. Mycoplasma is another type of bacteria. It has no cell wall, so it's very, very tiny. Commonly seen in the summer and fall, and in young adults, much more common in between the ages of 5 and 20. Another type of pneumonia, Legionnaire's disease, right? If you've heard of it, there's actually a Legionnaire's outbreak at Disneyland in California, because Legionnaires, the pneumophila, the organism, actually lives in water towers that are utilized to run air conditioners, and so condensers and cooling towers, right? You'll see fever, diarrhea, abdominal pain, liver, kidney failure, and pulmonary infiltrates. And so you need a macrolide antibiotic. I actually had a student once that told me that a friend of hers got Legionnaire's disease from an old hot tub. And I go, well, yep, that's possible. There probably was water sitting in the old pipes inside an old hot tub. You also can have some opportunistic pneumonias. So Pneumocystis jirovecii is a fungal infection that's very common in those who are immunocompromised, particularly with either cancer or HIV. Aspergillus, especially Aspergillus niger, which is black mold, right, is also another opportunistic fungal infection, especially for children. So released from the walls of old buildings that are being reconstructed, right? So what happens in pneumonia? You're going to see normal pulmonary defense mechanisms are compromised. So the organisms either enter the lung, multiply, and trigger this pulmonary inflammation. Inflammatory cells then invade the alveolar septa, and then the alveolar air spaces are filled with exudative fluid, right? Consolidates, and then they're very difficult to expectorate because they're so far down in your respiratory tree. And viral pneumonia doesn't really produce exudative fluids as much as bacterial ones do. So some clinical manifestations are going to be crackles and bronchial breath sounds over the affected lung tissue. So that's why we auscultate and listen to basically all of the lung, particularly on somebody's back, and then you listen to the front. You'll see chills, fever, and cough with a purulent sputum, but it doesn't always have that, right? So the severity of disease is going to vary in symptoms. So viral pneumonia started usually with an upper respiratory tract infection. So you might have seen fever and non-productive cough, hoarseness, coryza, and you might see wheezing and rales. Chlamydia pneumonia, right, is going to have a cough, tachypnea, rales, wheezes, and no fever. All right, so chlamydia can be found in the mouth, right? And so that can be aspirated, especially in patients who are hospitalized. Right, so mycoplasma, fever, cough, headache, and malaise. So we're looking for infiltrates on X-ray, the white shadows. And then a sputum from deep in the lungs could be taken from a broncholar lavage. And then the sputum can be also aspirated, and then it can be tested. And then the laboratory, you're looking for the white blood cell count over 15,000 white blood cells. And then the diagnosis can also use this curb determination, should be whether or not a patient should be hospitalized, including confusion, a blood urea nitrogen that is elevated, respiratory rate that is also elevated above normal, so about 30 breaths per minute or greater, a systolic blood pressure that is less than 90, and a diastolic blood pressure that is less than or equal to about 60, and if they're 65 years of age or older. So depending on those different characteristics, you may determine whether or not the patient needs to be hospitalized. Right? So antibiotic therapy, remember that in some cases, your different bacteria are gonna have either sensitivities or they're gonna be resistant. So one of the things might be a culture, sputum culture. Sputum culture may be used to find out which antibiotic that particular organism is most responsive to. Yes? You'll probably always start people on a broad spectrum antibiotic until you know better. Then severe acute respiratory syndrome is also known as SARS. You probably have heard it as SARS. So it's a coronavirus, right? Usually mostly transmitted from person to person. You know, SARS made its debut, if you could call it, about 2007 or so. So about 10 years ago or so. And it is passed on through respiratory droplets, coughs and sneezes. Also contaminated objects, and then surfaces of where you got contaminated objects, then touching the mouth, nose, eyes. All right. Many of these severe acute respiratory, you might have also heard of MERS, Middle Eastern Respiratory Syndrome. Those are going to be passed particularly in areas where there is a high population, where there is easier to transmit respiratory droplets. And so then it becomes more of an outbreak in that area. And then as it starts to spread, it can then affect other populations. So the pathogenesis is, right, virus is epidemic with usually a milder disease found in infants and children. Severe respiratory forms in adults. Remember, adults have a very strong immune system, so sometimes the immune system of adults just kind of overcompensates and can actually make the situation much worse. Median incubation period is between 4 to 6 days, and so with the patient becoming ill within about 10 days of exposure. It is a mortality rate of about 10%, with those who are elderly above 60 years of age at a much higher percent, over 50%. So the fever of 100 degrees Fahrenheit or higher, 100.4, right? Myalgias, headaches, non-productive cough, and dyspnea. So it's really important to be kind of aware of different outbreaks throughout the world, because if an outbreak happens in another part of the world, then patients, not patients, but people who might be carriers of the infection and maybe even be unaware of it are going to come and travel, right? So exposure to SARS or traveling to those high-risk areas. They have chest x-rays, right? Laboratory, which will check for the presence of the SARS virus. You might see specimens acquired from the nasopharynx, oropharynx, and sputum. Even stool specimens can indicate presence of the SARS virus. So no definitive treatment, because remember, it is a virus. So you basically are going to treat the symptoms of pneumonia, so which is may require oxygen therapy, even mechanical ventilation, and then hospitalization, of course. Isolation, right? So these are reportable diseases. So if a patient does have SARS as identified by your microbiology office at a hospital, that obviously needs to be transmitted. That information needs to be transmitted to the public health authorities and maybe even the CDC as an awareness that this is now an area carrying a potentially very life-threatening and easily transmissible disease. All right, so tuberculosis, right? The etiology is there's a estimated about 10 million people that are infected in the United States, right? Most people are high risk, especially that are previously infected, okay? Also malnourished and immunosuppressed, living in overcrowded conditions, incarcerated persons, immigrants, and elderly. So these are the highest risk individuals. Remember, tuberculosis was kind of a really big issue back around the time we discovered antibiotics. It has never quite been as severe, but it could be potentially very, very damaging to the lung. So there's an increase in what we call multi-drug resistant tuberculosis. Not so much in this country, but again, people can transport it to this country, right, by traveling to this country. Or, you know, if you were a nurse and you traveled outside of the country, there's a very good likelihood that if you are working with, you know, patients who are sick, that you could get tuberculosis. The multi-drug resistant tuberculosis is potentially fatal, because again, there are very few drugs that are going to be able to eliminate. But one of the things that has increased multi-drug resistant tuberculosis is the inappropriate use of the medications for tuberculosis. So not taking the medications on time, not taking the entire course of medications. And so in this country, when you have tuberculosis, you're going to see directly observed therapy for many patients, particularly if they are poor. So the public health department is going to send somebody to give this person their medication and observe them take it. So that's directly observed therapy, right? So cases of all tuberculosis, but particularly multi-drug resistant tuberculosis, are reported to local and state health departments, right? So Mycobacterium tuberculosis is an acid-fast aerobic bacillus. Remember, it has the mycolic acids in their cell wall, so it makes them quite sticky and a little bit different than other bacilli. They're aerobic, which means they require oxygen. That's why they infect the lungs and lymph nodes. And so inhalation of the droplets containing the bacteria that are usually expelled with cough, sneeze, or talking from person who is infected. Right? It can involve distant organs. So you might see hematogenous spread during primary reactivation phase of the tuberculosis. And you might also see disseminated disease where there is even tuberculosis sometimes in the spine. So you might see miliary tuberculosis and other hematogenous dissemination throughout. So in the spine, meaning like in the red bone marrow. Right? So classifications, right? So primary, and this may lie dormant for years, okay? Reactivating, right, may occur after years of primary infection, and particularly in people with affected immune systems, so immunocompromised, like with HIV, people with silicosis or diabetes, or even corticosteroid use, right? So entry of Mycobacterium into the lung tissue, right? And then alveolar macrophages ingest and process the microorganisms. Microorganisms destroy or persist and multiply, right? And then lymphatic and hematogenous dissemination throughout, and even in the T cells and macrophages in the lung can even cause those caseous granulomas, which are characteristic in the chest x-ray of patients with tuberculosis. So reactivation usually is only going to occur if immunocompromised, so immunosuppressed, right? And so manifestations that gone tubercle complex that you'll see, right, in a little nodule that becomes fibrotic and calcified in the parenchyma of the lung, and or in the lymph node and lymph components as well. So some of the manifestations is the history of contact with a person who is infected with the disease, a low-grade fever, a chronic cough is the most common. As the disease progressive, you'll see a productive and with sputum. Night sweats, very characteristic of tuberculosis. So chronic cough with night sweats and fatigue. All right, so you see weight loss, malaise, anorexia. You'll hear apical, remember at the apices of your lungs, apical crackles, bronchial breath sounds over the regions of consolidation, or those white areas on chest x-ray, and malnourished. So you'll see people with tuberculosis become very, very thin and waste away. Sputum culture gives you a definitive diagnosis, right? 3 consecutive morning specimens. Takes about 1 to 3 weeks to determine that because they're very slow growing. So DNA and RNA amplification techniques are also being used for diagnosis and pulmonary function tests. So see an x-ray, right? Very common with the infiltrates in the apices and posterior segments. The TB skin test, also called the PPD test, does not distinguish between current disease or past infection. And a lot of people receiving the Calmette-Guerin vaccine, especially from other countries such as Haiti and Cuba, people in Miami, right? You'll see them create this false positive PPD test, and often they will have to receive antibiotics for this disease, even though they may not have a recurrent or active disease, but they want to give them antibiotics just in case. So, right, and then therapy is 9 to 12 months. So yes, 9 to 12 months, and no drinking alcohol because it's very strong antibiotics. And so therapy is short in persons exposed with no active disease. So it's usually more like 6 months with people who are with a positive PPD that have no signs of active disease. And then when treatment failure is suspected, you might add more drugs to that treatment. Right? So safest, right? Most effective therapy for the shortest period of time is what we're looking for. So you might see directly observed therapy, like I mentioned, because non-adherence to therapy is the main cause of treatment failure. All right, so question number 3, what information is correct regarding restrictive pulmonary disorders? I'm going to let you read those, okay? And I'm going to end it here because my time is running out. So this case study, hopefully we'll have time to address it in class. All right, thank you. Bye-bye.